Yes, call the meeting to order. Oh, that's the running contract. The what? The running contract. What's who to who? Health Department to hospital. Who to the health department. Hired for hospital to that office. Is that about right? That's said every year. That's just a portion of it, this month's portion of it. So she'll have the handle. I'll call the Health Committee meeting to order. First item of business, public comments. Seeing none. Second item of business, agency reports. The only reporting agency would be the Health Department, who's next on the list. Dee?
I did bring a grant update list, but not having changed from last year. Right now, we're waiting on notification from the state. Typically, we have our grant set up. Usually in May, they're usually back at the end of May or early June. But many of the grants are on hold because the state agencies, the Department of Health, the Department of Human Services, and the IDOA, the Department of Agencies have not reduced their budget numbers yet. And many of those are not going to review that until the governor's budget is completed. So we expect significant delays this year in our grant contract. So it is a lot of that. We have those that I've gotten we were told in the Illinois Breakfast Social Grant, the governor had a 71% decrease in that grant. That came through at 50%. That one, is a 30% decrease. We're not sure what's going to happen with coordinating with health plan. That was actually a fair grant that we received back in 2004 that we didn't have because they were using our particular agency as a pilot. So we're not sure what's going to happen with that grant. But the rest of the grants seem to be stable. Local health protection grant funding here at 100%. We've already gotten our application in, we've got renewal, and I've done a contract. So many of our grants are pretty stable. We were notified yesterday that Illinois, which is the green grant, that I am a subcontract. It's $180,500. And then the fiscal year 15 was our current year by $1,175. So we know that our last payment that we get, probably for the month of June, will be decreased by $1,175. So what that means is that we're still in the contract that I am making, so we'll have to pay them their contract amount. But what that means is that before we, the current contract, well, this is going to before we negotiate any kind of a contract with them, we're going to try to find final numbers based on all three of those programs. And we've been told that they don't know when those numbers are coming. We've also been told that Ralph Schubert is with the IAEA, Women's Health Association, and we've been told by Ralph that there may be some funding for FY15. So any unused money that we don't have from Illinois, not federal grants, state grants that are unused, they can talk about the funding before the end of May and throughout June. So they were in agreement. I got something to brought that in and reiterated it, expressed that we use our grant money and we might get some funds back. So I'm very cautious of doing that now, because just like you say, by last Sunday, that they're setting it by 11, I wouldn't spend my money unless it was money that needed to be spent. But you also have some commitment for money in June. Great commitment that we need to make sure we get filled. So we take care of that a little early, just to make sure that those services stay in place with your people. So right now, we're waiting to see what the benefits are going to be and then go from there. And when we get numbers from Department of Human Services on our grant, our McKinsey Engineering grant, our Housing Management grant, and like what once I have those numbers, I'll be able to negotiate a new contract with IME, but I'm not going to try to get that and negotiate a contract. What we have to do is very possibility that we might have to do a month contract until we find out those numbers. So that's a concern right now. If you look over your supplemental report, it shows you the services from November through April, year to date, and what our numbers are like. The vaccine program has been approved. We actually haven't even gotten a record about that vaccine. So historically, we've had a VSA program, vaccine children, or uninsured children in the health department, and we do vaccines at a very low cost. And we now have that program for adults. We have not advertised it yet. We just went for training for that. We do have our vaccines in place, and we, during the Monday, will be advertising the press releases, actually, are advertising. Press releases, and letting the public know that we have vaccine for uninsured and underinsured adults. We're also looking into a program that is funded for implementing a billing service so that we can bill their private insurance. So that would really help us. We would have to away people. We can add private insurance coverage vaccines, or make them upfront costs, and then have to do reimbursement. The program is very expensive to implement, but we have to notify that qualify it, and they pay all the implementation costs. They're somewhere around the neighborhood of $30,000 for our program, and they're for the service. There was also some electronic health records which we don't have. No one knows about electronic health records. Those services are extremely expensive. Most health departments then have them, and most health departments don't have electronic health records. But many of them can spend anywhere from $20,000 for the service. We would be able to go to a company and still have lots of researching it. And we would be able to build private insurance and have our own health records that cost somewhere around $25 a month is our estimate. The service loans are $125 a month. But they claim about 14% of the revenue that we bring in. So let me give you guys an example. I didn't bring my list from before, but in Medicare costs, last year we paid approximately $600 Medicare. We had 88 of them on night. So we lost several $1,000. Between $27,000 and $9,000 in revenue, because what happens is people come in with their Medicare Part but they think that that's their primary insurance, and they tell you that's their primary insurance, but then I find out that's really secondary. They have a different primary insurance. So then Medicare won't cover the cost of the shop. There's no way for us to determine when they come in with their Medicare card, no way for us to determine eligibility. Okay? Especially in a remote setting like, at the Shelby Community Center or at the Crescent City Community Center. So, your services allow us to build a primary insurance in the Medicare Part B. So we would actually increase our revenue quite a bit. But whatever increase in revenue that we have, this company then would bill us for 14% of the increased revenue. I think I'll probably do it. We're looking into it. I know that Prince County Health Department just implemented their revenue. Prince County will do it. We're looking into it. Champaign County will go with our it's probably one of the better services that I really see. That capture a lot of interest revenue for us. But for us, it is about interest revenue. We're always looking for ways to interest revenue, but it's about increasing vaccine rate in the county and make sure that people who need a tetanus shot get one. Make sure that people who want a shingles shot can get one. And don't have to upfront $200 to get it. It's a lot of the cost of their barrier. So it will help prevent vaccine flu and other diseases in the county. Those are the new things that are going on. I told you at the time when we would talk about some community health programs. I have a PowerPoint that has all of our community health programs on it. We will not make it into a PowerPoint today. So whenever the meeting starts to end at 10, I'll just shut it down and we'll continue the next meeting. And we'll keep it rolling until you tell me to stop. How about that? Okay. So, when Sherry came in, you can talk about the environmental program. There we go. He told you that he has 2 staff members. Luann has 2 staff members. For the community health staff, we have quite a few nurses. Vonda Pruitt is our clinical disease coordinator. She is full-time, and that's their full-time job. She calls us as our office nurse. She does our blood training, our immunization, any blood pressure. She's part-time. Jane Newell is the Illinois Breast and Cervical Cancer Program nurse. She works 2 days a week in that program. That's one of the programs that I told you we've already been notified that we cut 50%. That's probably our largest cut for any of our programs. So Jane will be working with me after July 1st in that program 1 day a week. Deborah Longman is a staff nurse and also a floor nurse. She's 4 days a week. And right now she's covering as an offered school nurse. Teresa Castoni is a full-time staff nurse. She works 4 days a week under contract for the Unit County School District and one day a week under the Ford Liberty School Health Grant. Jane Newell. Oh, we got Jane on there twice. So you've already heard that name. And then we have additional registered nurses. I'm a registered nurse, so I fill in for all of our programs. So when we're short-handed, I put my administrative aside for a little while, go back to nursing. Louis Armstrong, our senior services supervisor, is also a registered nurse and can fill in for any of these nurses. And then Marie, who's our senior services professional, she can also fill in. And then we have one more staff that we consider community health staff, and that's Judy Buchanan. She's our certified vision technologist and our certified auditory technician. So we break our community health programs in 3 different categories. We have local health protection programs which are required by the state in order to be a certified health department. Then we have other county public health programs that are either county services or specific to great area or programs. And then we have our whole health program. So under the local health protection programs, we have communicable diseases, STD, TB, childhood and adult immunization. And those are the things that are required by law to be a certified health department, you have to offer those services. So for communicable diseases, we have a lot of, there are obviously a lot of state mandates and requirements. Those requirements come from either the Centers for Disease Control or from the Illinois Department of Public Health. There are more mandates and requirements than I can tell you, and I've decided not to start going over those with you. If you'd like to know about those, we can do that in a separate discussion. But the state legislation, state mandates, state statutes, state requirements all change with communicable diseases as diseases arise within your state. The categories for communicable diseases are either on the Illinois Reportable Disease List, or they're classified as other reportable disease outbreaks, or then you obviously have non-reportable diseases. Okay? So if you're not familiar with it, this is actually an older version, but the Illinois Reportable Disease List has a whole bunch of different diseases listed on it, and then in parentheses behind it, it has a number. And that number is the number of days that a local, that these diseases are reportable to your local health department. So in other words, like after varicella, chickenpox, it has a 7 after it. So within 7 days, doctors' offices, hospitals, clinics, laboratories have to report to the local health department that there's a case of that. And you can see that the list is quite long. This is an older one, like I said, this one doesn't even have a bill on it yet. But that's now become a reportable disease. So when we do municipal disease investigations, and what I mean by the components are interchangeable is that different diseases have different orders and different patterns in which we investigate them. So this isn't necessarily the order for every disease. But we do surveillance and communication with the schools, the hospitals, all local health care providers, and then through the state of Illinois Resident Health Notification System, Siren. I got a siren call last night about 5:30. They were just testing the system. But Siren is a notification system that notifies me if we have any kind of an outbreak or unusual cases, anything abnormal, and it's going on in our area. We report through the Illinois National Electronic Disease Surveillance System called INED. So if we're in Kansas, it's KNED. But INED is a system that we open up every morning. When I was a communicable disease for many years, and what I did when I came into work every morning was I opened the INED system. It has a whole bunch of firewalls that you have to get through and a lot of passcodes to put in. It's probably the most highly protected system in the Illinois Department of Public Health because it contains everyone's confidential information. Anyone in the state of Illinois who has any kind of a communicable disease and has tested positive for that disease, that information is put into INED. It used to be that the local health department imported that data into INED. And then I think it was around 2012, the state statute on that changed, and the laboratories who are doing the testing, so anytime that they test somebody's blood or any other body fluid, and that person tests positive for anything, the laboratories by law have to put that information into INED. So when we come in the morning, I can open it up, and it tells me everyone in Iroquois County who has tested positive for any communicable disease. So let's just say someone has tested positive for gonorrhea. When I come into work in the morning, I'll open INED, and it will tell me that this person who lives at this address with this date of birth has been tested positive for gonorrhea. It will tell me what doctor ordered that laboratory test. And then I start the investigation process by my first phone call is always to the doctor to find out, whether they've received a copy of the test or not. Usually, a lot of times, these laboratories put this stuff into INED, and then they'll mail a hard copy to a doctor. So a lot of times we get the results before the physician even gets them. So a lot of times what we're doing is we're notifying the doctor that the person tested positive. And then we always allow the physician time to contact that individual and let them know that they've tested positive for something. And then the doctors will tell them that the health department is reportable by law, so that the health department will be contacting you to do an investigation. And then we start the whole investigation process determined on what field form the Illinois requires us to ask. So some things might have a field form that's 2 pages long, and some things might have a field form that's 25 pages long. But that all comes right out of INET. And investigations can take anywhere from a few hours to a few months, depending on the disease. We use our local form, we use the state form, we use outbreak form, CDC form. So there's a lot of paperwork that goes along with that. We don't consider anything a case until we have actual laboratory confirmation. It used to be that physicians would confirm different diseases without laboratory testing. The states got really strict about that, and now for most states, to be considered a case, an actual case, we have to have laboratory confirmation on those things. We also have a system called the Illinois Outbreak Reporting System, or ORS. Things that are not on the Illinois reportable disease list, such as norovirus. You can see that I put that on our sheet, when we have norovirus, because that's considered an outbreak, especially if it's in a closed setting, like a school or a long-term care facility, like a nursing home. Those things are reportable. Anything that is communicable and causes an illness over 10% of the population has to be put into the ORS system. And that investigation can take quite a while because we have to keep illness logs on the staff, we have to keep illness logs on the residents, we have to do in-services, on hand washing and prevention. We have to put up signs on the doors that warn visitors that there's an outbreak occurring. We have to, whenever there's an outbreak in a long-term care facility or any kind of a setting where there's long-term population that's there for 6 hours or more, like a school setting, we have to collect at least 5 specimens and send to the state laboratory for testing to make sure that we're implementing preventive measures for the right illness. So it's all very interesting. Whenever we do an investigation, we have to get all the client information, their demographics, all their illness information, which can be paid with questions. And then we can find out who are their contacts or the exposed individuals. And then, like I said, we do the prevention and control measures where we do specimen collection and transportation, environmental inspection and recommendations, prophylaxis administration. And that prophylaxis administration could be anything. It could be antiviral, antibiotics. If it's a really bad case or something, it could be an antidote. Then we also have to consider quarantine, isolation, and social distancing. And I know I'm preaching to the choir here, most of you already know the difference, but when you quarantine someone, the difference between quarantine and isolation is that when you quarantine someone, you're asking an exposed individual who is not sick to stay away from other people. When you're isolating someone, you're isolating someone who's actually ill. They actually have signs and symptoms. So you quarantine the exposed and you isolate the ill. And then you ask for social distancing when there's an outbreak in the proximity. Sometimes this takes court orders. There have been cases where we had to threaten people with court orders. We had a month case once that the individual was highly contagious and refused to stay at home. So she was in the grocery store. She went to a local pool. She was in Dollar General. She was in several places. And when we called and asked her if she had gone out of the house, and she said yes, then we told her, you're exposing a lot of people, especially newborn babies and people that have not been immunized, and you're risking their health as well. So state statutes are really very clear about that. You can get a court order to order them to stay indoors, especially for tuberculosis cases. Many surrounding have not had to have that. The tuberculosis cases, the active tuberculosis cases that we've had in Iroquois County that I've been involved in, the people were voluntarily staying in isolation. So we didn't have any problem with that, but I know a lot of surrounding counties, it's in the news a lot, especially Champaign County's had several times where they had to get court orders for people to stay away from others. Some other factors for consideration are the community partnership involvement. A lot of times we have to get local doctors, hospitals, law enforcement, whoever involved in the situation. Costs are unbelievable. Just for a tuberculosis case alone, the average cost, because if you have an active case of tuberculosis, the state requires direct observation therapy now. So an active tuberculosis case in the state of Illinois, a registered nurse has to go to the home every day and watch that person take their medication regime. So in other words, in an active case, usually that person's on about 4 different types of medications for TB. So we have to watch them swallow their pills every day. And that's for several reasons. First of all, you want to make sure that the person is actually taking them, because you do not want to create a medicinal resistant strain of tuberculosis by having somebody who, as soon as they feel better, quit taking their medicine. Kind of like antibiotics. You need to take the whole regime, because if you get a 10-day prescription and you only take it for 3 days, because after 3 days you feel better, you're really doing yourself a disservice, because that you may be creating a strain that's resistant to medication. Because you haven't killed off that bacteria. What you've done is you've suppressed its growth enough that it becomes resistant to the medicine. So in the state of Illinois, the cost of somebody who has tuberculosis, the direct cost of their medication and their direct observation therapy, just those two things alone, not including any of the chest x-rays or sputum specimens or all that kind of stuff, the average cost is $10,000 per case. And that's what it would cost the county if we had a case. That doesn't include any of their contacts. And then we're seeing an increasing number of investigations, because obviously the Illinois Reportable Disease list grows all the time. Sexually transmitted diseases is another component. Those are reportable into INED. We also have an Illinois morbidity report that has to be completed with every case. There are non-reportable sexually transmitted diseases that are really prevalent. One of our most prevalent in Iroquois County is HPV, human papillomavirus, which we know can cause cervical cancer in women, and it causes venereal warts or genital warts. But that is a non-reportable sexually transmitted disease because of the prevalence. We always say that if the state ever makes that a reportable disease, we'll have to hire 2 more full-time communicable disease investigators. It would be unbelievable. Herpes is non-reportable because it's so prevalent. So we get those cases, but they're non-reportable. HIV and AIDS, we are a surveillance health department only. We do not do any kind of counseling or treatment or medication therapy through our health department whatsoever. We only do surveillance. So last week I got a new HIV case in Iroquois County. So what I did was, as soon as we were notified by the doctor's office that they had tested positive for HIV, then I have a 6-page report that has to be completed and sent to the state. And then the state will assist us in recommending where to send this person for their counseling and their medication and treatment. Right now, our referral for that is Champaign-Urbana Public Health Department. So we send everything there. There are very strict state federal guidelines with HIV cases. Those do not go into plan. There is no computer system in the state of Illinois that holds HIV cases. It's all done through paper. And even when we send in our HIV cases to the state, we send in the cases in 2 separate envelopes separately. So one of them will have all their information and an identifying number, and the other envelope will have the person's identifying number with their name. So that in case that would be accidentally opened, someplace, chances are both envelopes will end up lost. Or at the wrong destination. For treatment, Iroquois County Public Health Department is the provider of last resort. We only provide STD treatment if the person cannot afford them. And if they cannot afford them, then we will pay for them. But most of the time, that person can afford them because STD treatments are not expensive. In fact, most STD treatments cost $10 or under. We also arrange for partner treatment. We don't test the partner anymore. If they come in and they tell us that they are a partner of this person, a special partner, and we know that person tested positive, we go ahead and we arrange for treatment for them through the physician's office or through the health department. To test them would cost us about $45. Our most frequent one, STD that people need assistance for partners with is chlamydia. The treatment for chlamydia is under $5. So as long as they're not allergic to that antibiotic, we just make sure that they get treatment for it, rather than go ahead and spend them $45 to test them. And the state encourages that you don't test them, that you take their word. If they say that they have had sexual contact with that person, you take their word and you treat them. We do a lot of STD education. The only way that we're going to get these STD rates down is through education. And then other factors for consideration is emotional stress. You would be absolutely astounded at the number of cases that we are involved in investigating for sexually transmitted disease where a person is absolutely devastated. Even though that they participated in that risky behavior, they did not think that this was going to happen to them, and they are emotionally distraught. They can't believe that it happened to them. It also can affect a lot of families, especially if I'm not even going to go into tuberculosis today. A lot of families, especially if you have, for example, a couple who are married and have been married for a long time, and one of them tests positive for an STD. Obviously that's an issue. So we have to spend a lot of time in order to educate them. We have to get them emotionally prepared to hear that education and to be receptive to it. So there's a lot more to it than just saying, okay, you tested positive for chlamydia, here's your treatment. And the nurses are very well trained to do that. And the one thing that we assure everyone is that their information is kept confidential. I work as a public health nurse for Iroquois County or Fort County for over 23 years. No one can ever say, G. Shippers or any of those other nurses said so-and-so had an STD or this person's HIV positive. It doesn't happen. Our nurses would never betray someone's confidentiality, not just because of the HIPAA regulations and HIPAA laws that we have in the state of Illinois, but because we wouldn't put our nursing licenses on the line. We know that we wouldn't win a case if we were sued civilly. So that information is always kept extremely confidential. No one can get into that INED system at our local health department except for the community public disease nurse, Vonda Pruitt, Judy Cox, culture of the office nurse, Deb Longus, who is our backup, and myself. We're the only four that can get into that system. Sometimes we have trouble getting into our own system. There's so many passwords and things that change. But we want to make sure that the public knows that we're there to help them. We're there to help prevent the spread of communicable diseases, and that all the information that they give us is kept confidential, especially for those communicable diseases. Now, there are communicable diseases that are exempt from HIPAA regulations. For example, tuberculosis. There are laws that allow us to notify the public that we have a case. We wouldn't necessarily share that person's name, but we can let the public know that we have an active case in the area. If you have a measles or a mumps case, state encourages you to do press releases to let the public know that there are cases out there. That way, if you're unimmunized, you have the opportunity to know that those are in the area, and you can go get immunized, or you can, avoid large social populations where the risk of exposure would be increased. So those are just a couple. I have probably 40 more slides that we could go through, but I'll stop here and do a little bit of each meeting. How does that sound? Okay?
That'll work. Next month, the following month, maybe not, because we're going to try to get the agencies to report over the next 2 months. So if there is some fill-in time, though, most definitely.
Okay, that sounds great. Do you have any questions? Well, if you think of something, feel free to give me a call. We like to talk about what we do. Information overload.
Thank you, Dee. The next item of business is the claims. Everybody's had a chance to review the claims report. You can actually look at the hard copies if you'd like. Pardon? It's been moved, seconded by Brett. Is there any discussion on the claims? Seeing no discussion, all in favor say aye.
Aye.
Opposed, same sign. Motion carried. Old business. I have one item, and that's, we talked about last week, roping in the reporting agencies to the health committee. Look at my list. Those agencies are the Public Health Board, the 708 Mental Health Board, Board for Developmentally Disabled Persons, Veterans Assistance Volunteer Services, ARC, and ABRA. And in your pile of papers, I drafted a letter to send to these agencies to get them to come next month or the following month, and my intentions were, in the first paragraph, they get back to Amanda to report next month, and those who don't, she would track them down, and we'll get that the second month, and maybe we can split them up a little bit to keep the time down. So I would entertain a motion to approve that letter to go out to those agencies.
Could you make some corrections on it?
Yes, I can read the corrections. It's the time, which instead of 9:45, we'll put 9:30, so we're here in time. And then after the time, the sentence should read, the county board respectfully requests that the administration of your agency attend monthly to update your programs and financials to the health committee. Just a little better wording on that sentence.
Would we be better off to suggest regularly as opposed to monthly, or is the desire in the beginning to get them here every month?
do it monthly, just to get them in here regularly, because obviously in a year's time, nobody's reported, to my knowledge. I don't believe anybody's come in.
Not since the first, not since the beginning, as I remember.
Veterans were the last one. I think so.
Can they be mandated? Can they be mandated to next month, to next month? after
Well, I
that?
think that could eventually go, but I think what everybody needs to understand is that we control the purse strings, so,
Well, yeah, but
we could get their attention pretty quick at budget time, for sure.
yeah, but we don't want that, do we?
No, but we need to make sure that they're following.
We need at least
Formally
quarterly,
We
invited.
shouldn't be chasing them, they should be really...
minimum quarterly reports, I would think.
after us. I think we should, my opinion is to let it go monthly, and we'll see who wants to participate. And their level of participation could be the results of that. They're working for the taxpayer, that's what we need to remember. We're just the go-between. Anybody want to move? Oh, Gene.
We had them report quarterly.
Quarterly?
Yeah.
It used to be.
Either bi-monthly or quarterly. And that seems to work very well for most of them.
But I think as Dale might have pointed out a meeting or two ago, that would work well, but I think we should give them specific months so we spread them out throughout the year. And we should make a schedule, and maybe when they do their yearly report here, we'll actually give them a month or months. Maybe their agency works better reporting every month, bi-monthly, depends on how their financials work too.
Some of them years, fiscal years are not spending hours.
That's correct. Then move. Do I have a second? Seconded by Dan. Any further discussion? All in favor to submit the letter to the agency, say aye.
Aye.
Opposed, same sign. Motion carries. Any other old business? Any new business? Seeing none, I would entertain a motion to adjourn. Moved by Jed, seconded by Brett. All in favor to adjourn, say aye.
Aye.
Opposed, same sign. Meeting is adjourned.